My talk tonight is going to be about spirituality and not ethics. Some caveats before we start, one which should be obvious: no slides, which is good. Power corrupts, but PowerPoint corrupts absolutely. The second is an important, for you to understand what I'm going to do, is that for 25 years I had been a Franciscan friar, a member of a Roman Catholic religious order. I'm now married for going on 12 years, but this story I'll relate to you tonight took place while I was still a friar, so that will provide some context. And I also want to start out by saying that spirituality, in my view, is ultimately particular. In language and in images that you're going to hear are going to be very inflected by my particularity in my Catholicism, my Franciscan spirituality. And this is not meant to exclude anybody, but to be sufficiently authentic and personal to reach a space that I hope will be deep enough that it might resonate with you wherever you are as a person on a spiritual journey of your own. And the method, despite what a lot of people know for me as being very analytic, is going to be totally narrative. I'm just going to tell you a story. In the end, I would fail him. It was as inevitable as the rain. I knew it from the beginning. See, I was the ethicist on call for the second week of November. A nurse called and said that a patient wanted help with an advance directive, and I waited till the end of the day after first attending to some emails and editing, and then trudged over to the hospital to the cardiac step-down unit. Not too many requests for living wills here, I thought to myself, knowing that most cardiologists don't actually believe their patients ever die of heart disease, just they sometimes succumb to comorbidities like diabetes, or else they die when the code is called off. And in the latter case, it wouldn't be heart disease, but rather the failure of technology that did them in. In any event, it was just plain unusual to have a patient on a cardiac floor fill out an advance directive. Otherwise, a routine request, I thought. I'd take a few minutes to explain the difference between a living will and a durable power of attorney for health care, recommending that the patient execute a proxy and letting him know why. And then I'd leave him with some blank forms and be on my way. Usually, this sort of task is delegated to patient representatives. Sometimes, however, patients insist that it must be the ethicist with whom they speak, and I'm happy to do that if that's the patient's request. In fact, I had done so for a patient in the medical intensive care unit just the week before. Wasn't anticipating a full-blown ethics consult with a dilemma or disagreement or some other knotty problem. The request seemed routine enough that I didn't even bother to look at his chart before I entered his room. "Mr. Fred Finnerty?" I inquired. He nodded his head. He looked a bit disheveled. He was obviously frightened. He was 64 years old, on the short side, a bit overweight, mostly bald, with a snow-white, untrimmed beard. The places where the razor should have cut his face back to the bare skin were peppered with a gritty white stubble. His voice was unpleasant to hear. A strong New York accent combined with a kind of whiny lilt. "I know who you are," he said. "You're that Dr. Sal Macy. I met you after a lecture 6 months ago, you remember? We invited you to talk at our chapter of the Sarah Club, that group that promotes vocations to the priesthood." I had only the foggiest recollection. "Oh, yes, I remember. Good to meet you again. I understand you want help filling out an advance directive." "I got lung cancer, "No, I didn't know that. I didn't look at your chart." "Would you be my doctor?" "Excuse me?" "I heard you lecture. And I said to myself, if I'm ever really sick, I want that Sal Macy." He spoke so earnestly that his head leaned forward on his neck and his eyes seemed to strain forward out of his skull, each held in place by its optic nerve the way a leash holds a dog in place upon meeting another dog. But you have doctors caring for you now, don't you? Yeah, but they're for the cancer and my atrial fibrillation. I need a regular doctor. I know I can't be cured. I want a doctor for when things get bad. And I don't want a feeding tube or nothing. I'm a Catholic, and I don't want anybody telling me I got to have one. I trust you. Now, this, to be honest, is one of the problems that accompanies the giving of public lectures. If you sound sincere, people believe you. They might even believe in you. And if they do, this forces you either to try to live up to their expectations or avoid getting involved. Sane people avoid such situations. We doctors, known for our outsized egos, climb right up onto the table, onto the pedestal, and pose. Sure, I'll be your doctor. Let me go back to the nursing station, read over your chart, and talk to you and examine you. That's how it began. He had metastatic non-small cell lung cancer. He'd been diagnosed in September. It was now November. He was receiving Tarceva, at the time a relatively new and mild anti-cancer drug with some activity against lung cancer. He was also receiving radiation treatment to painful bony metastasis in his right shoulder. He had been admitted with fever and a cough, possible pneumonia. His blood was very thin, a consequence of an interaction between the Tarceva and the medicine he was taking to prevent blood clots and associated with atrial fibrillation, the disturbance in his heart rhythm. I'm gay, you know, he said as I was listening to his lungs. I had already surmised as much. And an alcoholic, but I go to meetings. I've been sober 25 years. I'm a friend of Bill's. One day at a time, I muttered. Yeah, he replied. Now take a deep breath in while I examine your belly. I know a lot of priests. Oh, really? Where from? AA? You know, you can't ask me that. His heart had been beating too quickly when he was admitted. The cardiologists were giving him medications to slow down his heart rate, but one of the side effects was to lower his blood pressure. He couldn't stand up without becoming dizzy. Complicating matters, he was having side effects from the Tarceva, a rash and diarrhea. And the diarrhea had caused him to lose large amounts of body fluid, making his blood pressure even lower. A couple of liters of normal saline seemed to do the trick. His blood pressure came up, his heart rate came down. After a week in the hospital, he could go home. When I saw him at the office 5 days later, he didn't seem to be doing well at all. His blood pressure was still lower than I wanted it to be, and his heart rate still too high. He was nauseated from the Tarceva and still having diarrhea. I tried to get him to take in more salt, soups, pretzels, crackers. You've got to keep up your fluids, I admonished. He was also short of breath when he tried to walk. His oncologist blamed it on his heart. I thought it was perhaps all the nodules of cancer in his lungs. The oncologist also thought the Tarceva might be helping him. Having looked at Mr. Finnerty's x-rays, I found it hard to see how he could draw such a conclusion. I sometimes wonder who's more likely to be in denial, cancer patients or their oncologists. Here's my healthcare proxy form, said Fred. I named Father O'Malley. He's a good friend. Thanks, I said, and I put a copy in his chart. If I need it now, we'll know who to call. I want to go to that St. Clair's hospice when my time comes, he said. I don't like Mount Carmel. They weren't very nice to a friend of mine. He wanted to go out on passes, and they wouldn't let him. They were like the nuns in my grammar school. So much attention to law and order, they lose sight of the big picture. Okay, Mr. Finnerty, I understand that it takes a long time, however, to get people into St. Clair's. They're always running full, and there's a long waiting list. I can wait. I do live alone, but I cashed in my life insurance and I can use my IRA. I got aides coming to the house and I can get them round the clock if I need them. The nurses come 2 days a week and the physical therapist 3 times. I think it would be easiest to stick with the home nursing service till a bed opens up. But if the list is so long, why don't you just open it up for me and put me on it now? Well, I said, well, let's wait and see what the oncologist says about the Tarceva. It might stabilize your disease and give you more time. We need to say that you have 6 months or less to get you onto hospice. Actually, I believed he probably was already eligible for hospice, but this was the first patient I had seen who was being treated with Tarceva, and I didn't want to challenge the oncologist with my general internist's limited knowledge and experience, and I didn't want to undermine the oncologist's message to his patient. Not only did I say what I did to protect the patient from a potential dispute among his doctors, I was also something of an interloper. He had brought me into his care right under the nose of the oncologist, and the oncologist might be worried that the ethicist was stealing the patient away from anti-neoplastic therapy into the world of palliation. So I decided I would go with the oncologist's line about needing to wait a few more weeks to do a CT PET to see if the Tarceva was working. 2 days later, he saw the oncologist, who immediately readmitted him to the hospital. The nausea and the vomiting about which he had complained to me had worsened. He had become dehydrated again and nearly fainted. His blood pressure remained too low, his heart rate too high. The Tarceva was stopped, and he received intravenous saline once more. His nausea dissipated, his blood pressure came up. We discharged him on a lower dose of Tarceva to see if he could tolerate it any better. But 2 weeks later, in the face of more nausea and diarrhea, it became clear he wasn't tolerating the drug at any dose. And I decided now that he was really too sick to see me in the office, so that I would start making house calls instead. Will they give me IV treatment at St. Clair's? Well, Mr. Finnerty, they usually don't do that in hospice. The wisdom of palliative care nurses is that it's actually better to not have the fluids. You might just cough up more if you have more fluid. But what about today? Well, can't you just drink salty liquids like soup? Nothing staying down, Doc. Well, you still are dehydrated. In fact, it was hard to tell how much his drop in blood pressure upon rising from the bed was due to deconditioning and how much from dehydration. He had, in my judgment, taken to bed much earlier than he needed to. He had, it seemed, a lot of acquaintances, but it was hard to tell if he had any really close friends. I gradually learned that he had been estranged from quite a few members of his family. One of his cousins, a priest, had accused him of murdering his mother by not authorizing the use of a feeding tube as she was dying of Alzheimer's. He stated that he was close to a few nephews, but it seems this was a source of strain in his relationship with their parents. He was a frequent AA sponsor, and some of his fellow alcoholics visited him as well. So, I guess we can give you some more normal saline by vein. I'll check with the nursing agency. But this is no substitute for good old chicken soup. I want you to keep up with your fluids. So began a ritual of twice-weekly normal saline infusions. Even when we had succeeded in controlling his nausea, he still kept insisting on the saline infusions. From a purely biomedical point of view, I think these infusions were superfluous. From another point of view, however, I think they were grossly inadequate. I simply came to regard them as a kind of placebo that seemed to help him. A week later, I received a call. I think I'm dying. Oh, okay, Mr. Finnerty, easy now. Tell me what's bothering you. I got more pain in my shoulder, I'm nauseous again, and my stomach hurts, and I ain't had a bowel movement in 3 days. Easy, Mr. Finnerty. Has the nurse been in today? Not yet. Are you taking the Senecot? Nah, I thought I could just get by with the Colace. And what about your Tylenol number 3? I don't want to try that stuff, I'm an addict. Mr. Finnerty, I think we can take care of this. I'm going to order pain meds. You're not going to get addicted, and you're not going to be a martyr. Listen to me. We'll give you an enema and some pain medication and get you back on Senokot. And we'll keep you taking the ondansetron as well. And if that's not enough, I'm going to order a suppository for your nausea. You're going to be okay. You mean I'm not dying? Certainly not today. How do you know that? Well, because people who are dying usually aren't well enough to call their doctors on the phone to tell them that they're dying. Every problem you have is fixable. When then? Well, not today. What about Sinclair's? Well, I'm told you're number 2 on the waiting list. Hey, that's kind of morbid, ain't it, Doc? Waiting for other people to die? Okay, I'll give them a call. Hey. Also, can I have your beeper number? I won't abuse it or not, and I just want to have it in case I can't get you otherwise. Sure, Mr. Finnerty. Sure. In total, I made 5 home visits. As much as I urged him to get up out of the bed, I never found him anywhere else but in bed when I arrived. The apartment was well lived in and filled with statues of saints. He had a book for reciting the prayers of the Liturgy of the Hours, something generally only used by priests, brothers, and sisters at his bedside. His rosary beads were never far away. Most of the time, they were wrapped around his right hand. He was blessed with an exceptional cadre of nurses and home attendants. The attendants kept trying to get him to roll over and lay on his side to prevent bed sores. He wasn't very compliant. They were all young Mexican women who were at least as pious as he was. And they also made great chicken soup. I'm afraid I'm going to be damned, he said to me one day, his eyes again straining out of their sockets. Well, you've received the sacrament of the sick and you've confessed, haven't you? Yeah, but I'm still afraid. Mr. Finnerty, I think you need to believe in your heart what you profess with your lips. I believe God loves you. Don't you? I don't believe God wants you damned. What did this guy want from me? After all, I have to confess, I really didn't like him. He wouldn't have been my first choice for a drinking buddy. I didn't like the sound of his voice. I especially didn't like his neediness. It was a really busy time for me with grant deadlines and writing assignments and speaking engagements, and every time I went away, I left complicated instructions for him about how he could reach me. In truth, he never once abused the privilege of having my beeper, but I hadn't given my beeper number to a patient in years, perhaps because none had been nervy enough as Fred had been to ask for it. Nor was I in the habit of making home visits on a regular basis. They're very hard to work into a physician's schedule. I figured out that the simplest way for me to do this was to make it first thing in the morning. I'd go to his apartment by subway on my way to work. That way the whole task could be accomplished in about 75 minutes, including the visit itself and the extra travel time to get back to my office at the hospital. I brought a medical student with me one day. She had never seen a doctor make a home visit. The visits to Mr. Finnerty's apartment were at least somewhat helpful medically, but I could have easily relied upon the nurses' assessments without ever visiting. They really were excellent nurses. They had extraordinary patience with him. So, for instance, when he demanded a special air-cushioned bed, and they tried to explain that his insurance wouldn't pay for it because he didn't have any bed sores, his primary nurse, Tom, dutifully called me explaining to Mr. Finnerty that he didn't think that the chair of the ethics department was going to lie in order to get his patient the insurance coverage. Every visit was difficult to conclude. Since I was on his turf, I couldn't rely on the rattling sound of the chart of the next patient being placed in the slot on the door as a convenient prompt for me to suggest that the visit must draw to a close. This is an old story. That only worked in the office. Mr. Finnerty especially loved talking to me about church gossip. Who would be the next Archbishop of New York? What did I think about bishops denying communion to Catholic politicians who supported abortion? Now, one of the times I was out of town during the time I was caring for him, it was to give a talk on, like tonight, spirituality and healthcare. And it was a workshop, and as part of that, I invited the participating physicians to spend 10 minutes thinking about just one patient. It's a useful exercise. It's often extremely difficult for physicians to do this, to just think about one patient. Studies have shown that even when the patient is present and starting to say what's wrong, physicians on average interrupt within 18 seconds. As a gesture of solidarity, when I was asking my colleagues to do this, I participated in the exercise myself. And not surprisingly, it was Mr. Finnerty who came to my meditation. Within a few moments, my meditation had turned into a litany. I could see his face and I could hear his voice. And I prayed to myself, Lord, have mercy on Fred. Fred, have mercy on Fred. Lord, have mercy on Fred. Over and over. You know, although he was never exactly cheery, his mood gradually became bluer. And I began to think that in retrospect, perhaps even his reluctance to get out of bed might have been a sign of depression that I'd been overlooking all along. Do you think you might be depressed? I asked. I think I am, he replied. Have you ever been depressed before? Yeah, when my lover died 25 years ago, I was really bad. They put me on some medicine. Do you remember what it was? It was a long time ago, Dr. Sal Macy. Now, I will say that it's always been a puzzle to me how there are so very many gay people who can reconcile themselves to the church and its teachings, live lives that directly conflict with church teachings regarding homosexuality, and yet are so obviously traditional and devotional in their religious practices. I thought about inquiring, but then thought it might have just been curiosity on my part and probably not helpful. Perhaps it might stir up too much that had long been buried deeply. It might even be harmful. Better to leave it to the mysteries that only God knows. I decided I wouldn't ask. Just don't ask, just serve. Probably as good a policy as there is for physicians. So I just prescribed some paroxetine. Since he lived alone and was fixed on the idea of going to an inpatient hospice, we had never applied for a home hospice program. We had decided that the regular home care nursing program would be good enough as a bridge to hospice. In fact, it was more than good enough. 11 weeks after stopping the Tarsiva and having immediately made the application to St. Clair's, he had still not been admitted to this inpatient hospice. Waiting times for inpatient hospices can be extraordinarily long. Most of the best hospice time he had was spent playing that morbid game of waiting for other people to die. In fact, however, he really had hospice care without the name. The home care nurses who attended to him were wonderful. His aides, that cadre of young Latinas, were strong and joyful, delightful and caring. He'd had very little pain through the course of his illness. He never did develop a bed sore, despite his early trouble with diarrhea and the fact that he infrequently left the bed. But he did lose weight. His appetite remained poor. Through it all, though, he could still read the newspapers, pray the rosary, and tell people what to do. In examining him, I found that he was free of jaundice. His lungs were clear, his liver only mildly enlarged, but I felt a new right supraclavicular node. With my fingers lingering there just a few seconds to confirm the finding, he felt me feeling it. What'd you find? A lymph node, Mr. Finnerty. That means I ain't got much time left, huh? I don't know that it means that. I think it does mean that the cancer is growing, but you probably didn't need me to tell you that. Does it mean it's going to go to my brain? No, I don't think it means that. 2 weeks later, at the end of February, however, things suddenly did change. He began to complain of more pain in his shoulder and abdomen. Up until that time, Tylenol number 3 had been sufficient, but now we changed over to hydromorphone since he had some in the house. He called my office one morning, sounded a bit confused. The aides began to panic. I called and asked his nurse Tom to see him to let me know what he thought, and when he called, he said, "I think he's dying, Dr. Sulmacy." Well, maybe we need to start a morphine drip. He does have a Heplock in place for the saline so we can just hook him up, but it's Friday afternoon. The home infusion team is going to be tough to mobilize. Can he still take his pain medicines by mouth? I don't know, let me see, Tom replied. Maybe if I crush the hydromorphone and put it in some pudding or something, he can take it. He called a few minutes later to report that it had worked. And later I spoke with the supervisor for the home care nursing team. "We need a plan for the weekend," she said. "I'm with you," I said. "I'm just trying to sketch out a plan myself." See, the IV and home infusion team had confirmed that they couldn't come until Monday to start intravenous morphine. The home health aides weren't legally authorized to give injections, so sub-Q morphine was out. And the smallest fentanyl patch available was still too potent, given how little pain medicine he'd been requiring. The supervisor for nursing tried calling pharmacies, but none of them stocked morphine or hydromorphone as suppositories. "I'm an old hospice nurse," she said, "and so is the nurse covering for Tom over the weekend. We'll just make our own suppository out of crushed pills if we have to, and he can't take the medicine by mouth." "A deal," I replied, "and I'm around all weekend. I'll keep my beeper on and certainly be willing to sign the death certificate." I visited him for the last time that night. I needed a complex plan just to get to his apartment. I was scheduled to drive out to Long Island for an overnight day of recollection with my local friar community at a small retreat center. Further, I had promised a young friar who had just started chemotherapy for acute lymphoblastic leukemia at a nearby major cancer center that I would visit him that same night. I also realized I'd left my cell phone at the friary and I wanted to have it with me while I was on retreat in case I was out walking and someone called about Fred. And of course, they were predicting a big snowstorm. So in the end, my plan was simple: to go steadily north before heading east. And accordingly, my first stop was Fred's apartment. I parked illegally to save time, hoping I wouldn't get caught. I didn't bring a stethoscope. I didn't bring a prescription pad. One of the young Mexican girls answered the door. "He just to take the morphina," she said. "Good," I answered. He was lying in bed, as always, rosary beads wrapped around his right hand. The New York State out-of-hospital do not resuscitate order form was appropriately clipped to the bedboard. I'd helped him fill it out. I knew it was the correct thing to do, and yet now it seemed awkward and intrusive, almost a desecration of a sacred space. "Mr. Finnerty, it's Dr. Sulmacy. Are you doing okay? Are you comfortable?" He opened his mouth, but he didn't speak. He raised his head for a few seconds and opened his eyes. Then he closed them again, and his head fell back gently upon the pillow. He was breathing about 20 times a minute. His pulse wasn't palpable at the wrist, but as I touched his abdomen to make sure he wasn't in pain, I could feel his abdominal aorta beating forcefully. The rate was probably 120. I didn't bother to count. His right leg was bent up at the knee, raised off the bed and trembling. I gently touched his knee and eased it back down. The aide positioned a pillow under his left leg so that the right ankle would rest upon it as well. "Easy, Fred. I think you'll feel better this way." And a mild look of strain disappeared from his face, melting into the peace of the morphina. I held his hand and prayed, "Time for night prayer, Fred. Protect us, Lord, as we stay awake. Watch over us as we sleep, that awake we may keep watch with Christ, and asleep rest in his peace. Lord, now you let your servant go in peace. Your word has been fulfilled, for my own eyes have seen the salvation which you have prepared in the sight of every people, a light to reveal you to the nations, the glory of your people Israel. May the all-powerful Lord grant us a restful night and a peaceful death. Good night, Fred." I turned to a young man who had been sitting silently in a chair in one corner of the room. His bare arms were heavily tattooed. One of his nephews, maybe an alcoholic he'd sponsored at AA. I really wasn't sure. I just said, "It's good that you're here. Stay with him." And I left the apartment. Within a few moments, I found myself driving up to the cancer center to visit that young friar, John, who had recently started chemotherapy for leukemia. The headlights rolled past on the opposite side of the highway, and I felt as if someone else was doing the driving, and I was merely going along for the ride. I headed north in the darkness, vaguely conscious of the river to my right, vaguely conscious of my visit with Fred behind me. And yet I couldn't stop asking myself a new question. Why John? Or rather, I was asking God, why all the good, young, energetic, healthy friars? The shift from Fred to John felt like a film editor's splicing mistake. The scene had changed, but the scene was from another movie, and I was in both scenes in this odd supporting role. You see, another good, young, energetic friar of our province had recently been diagnosed with multiple myeloma. We were barely past the pain of that diagnosis when we learned that John had leukemia. Don't you realize how strapped we are for vocations, Lord? How we're pulling out of commitments to parishes and other places because there aren't enough young friars? Then I thought to myself, so much for my theological sophistication, praying a prayer like that. But these sorts of questions in the end can't be explained away by ratiocinations. I think they come from the lung, not the cerebral cortex. I wondered how John would really do. His prognosis was really not very good. I wondered whether the time would come when my visits to John would be like my visits to Fred. The alpha and the omega of cancer treatment, all within this 90-minute span. Was this the avant-garde movie I was living? As I continued driving up the highway toward the cancer center, I also remembered that I needed to go to the friary to pick up my cell phone. I was fearful that I might forget this task and just drive out to Long Island immediately after visiting John. So even before I reached the cancer center, I was reminding myself to remember. After all, I was still planning to take my usual walk along the beach that following morning, and I would carry my beeper and would also need my cell phone because they might call about Fred while I was walking out and praying, and I needed to be prepared because that could happen at any time. And my geographic plan actually seemed to work. I visited John, I drove to the friary, I picked up my cell phone, I drove out to Long Island to the retreat place at the beach, and I had beaten the coming snowstorm. Very efficient, just like a doc. Now, one of the friars with whom I lived had gone to the retreat house earlier in the day, and he had prepared a late dinner for the two of us. It was a Friday in Lent, so we ate fish, sole stuffed with crab meat, hardly penitential. We had a nice dinner. I said nothing to him about Fred, and merely mentioned that I'd seen John and that he was doing okay. We had a lively conversation that I found pleasantly distracting, and before we knew it, it was after 11, so I washed the dishes, picked out one of the guest rooms, and prepared to go to bed. The snowstorm that had been predicted by the weather forecast never did arrive. In its place began a torrential, windswept rain blown in off the ocean, beating with a rhythmic tapping against the northeast window of my room. No snow, no sleet, just the rain. I charged my cell phone, placed my beeper on the nightstand next to the bed. I was waiting for that call. It might well come during the night. I would instruct the nurses and the family, bring a note of calm, and finally bring Fred's story to a close. Whatever he wanted from me, he seemed to want me to be with him for the final journey, and I was determined to see it through to the end. I didn't use a prayer book that night. I was tired, so I prayed the Canticle of Simeon to myself, once more from memory. Night prayer again, but this time for me. And I fell asleep. I awoke the next morning at 6:30 in the grayness of a cloudy sunrise, before the alarm. I was seized with a sudden sense of panic. The rain had become more soft, but it hadn't stopped. I never changed the beeper signal from vibrate to alarm, I thought to myself. What if it went off and I didn't hear it? And I fumbled for my glasses and pressed the message button on the beeper. Urgent, 3:42 a.m. EST, it read. I pressed it again. Urgent, 3:35 a.m. EST. Shit. I shook the fogginess from my head, rubbed the sleep from my eyes, reached for my phone, and dialed the callback number. A woman answered with a voice so cheerful that it jarred me. I began to mumble, "I suspect you're the nurse who was covering for Mr. Finnerty over the weekend. I'm really sorry. I just woke up and realized that you paged me in the middle of the night. I'm really sorry. I put the beeper on the nightstand next to the bed, but I forgot to change it from vibrate to alarm. I said I'd be available all day and night. I'm sorry." "Oh, no problem," she said, and it dawned on me from her cheeriness that she had been up all night and hadn't gone to bed yet. I got through to the covering internist, Dr. Weinstein, and he took care of everything. He was really pleasant and cooperative. You should know that Mr. Finnerty's death was very peaceful. His family and his friends were there with him. It all went very smoothly. The funeral parlor is going to call you on Monday to sign the death certificate. That's at least good to hear. Thank you so much. Again, I'm sorry. No, not a problem. It was a pleasure to call to care for him. Now, if you'll excuse me, I'm going to bed. The showers were now alternating with hints of sun. I looked out the window and saw a small patch of blue amid the lessening gray. I knew that the rain would eventually stop and I'd be able to go out onto the beach for my walk after all. The weather cleared and I did make it to the beach. And I walked along the ocean for hours. The salt air and the sound of the waves seemed just right. And as I walked, I could not stop thinking about Fred. Every once in a while, as I stopped walking, I turned from the beach and looked out over the wide, storm-stirred ocean, seemingly endless in its expanse. Myriads of sunbeams were striking the surface and dancing in angelic and brilliant ballet. You know, at such times, the ocean can seem infinite. And yet I knew that it was not infinite. I could see the horizon, and horizons enclose us in the finite. Even this massive ocean, I thought, even this Atlantic Ocean was finite. Fred had demanded salt and water. But even the depths of this ocean would not have supplied enough saline for Fred. He so desperately needed the salt of the earth. If we could have infused all of the saline of all of the oceans in the world into his veins, it would not have been enough. My guess is it would not be enough for any of us. I prayed that Fred's needs were now fulfilled, and that all the neediness I saw in him and knew I could never fulfill had now been fulfilled. And I began to thank Fred now for all he had taught me about my own needs and my own insufficiency. I sensed, too, somehow that I was not alone. When I looked around, I couldn't see a soul, but I had a sense I was not alone. Not now, in my walking. Not then, when I visited Fred, or had seen him in my office, or in the hospital. Had Fred ever seen who was with me? I wasn't sure, but I finally realized as I walked along the beach and prayed that it had not been me that Fred had been looking for after all. Not ever. Never. Because each time he asked me for something or asked someone who cared for him for anything, a sleeping pill, a hospital bed, an enema, another infusion of saline, he was really looking for someone else. Had he noticed? I knew that I had not noticed, at least not up until that moment. Because I had thought all along that Fred was looking for me with his pleading eyes and plaintive voice. And I had quietly resented his calls because I knew that I could not fulfill all his needs. But I began to see it all differently then, at least at that moment, walking on the beach after the rain. The beach had been deserted all morning. It had been cold and windy. The rain had only just stopped. But as I walked further down the wet sand, I finally did see someone else. Another crazy person who had sought out the solace of the beach in winter. Far up ahead, standing by a fire at the edge of the foamy waves, I saw the outlines of a man. The image was indistinct, but he was warming his hands over the fire. I wondered if Fred could see him now better than I could. The vision of the dead is sharper than the vision of the living, or so they say. As I drew closer, I could make out his wading boots and tackle. A surf caster, I thought, as I watched him toss his line into the sea. Smart guy. First on the beach. The fish are always more abundant after the rain. Did Fred see him too? I hoped that he did. I smiled, looked at my watch, and realized it was getting late, and I turned around and headed back down the beach to the retreat house, where the friars would be expecting me for midday prayers.
To hear you tell this story and to see you get choked up thinking about it kept having come to mind that idea of detached concern, which the sociologist Renee Fox described as which she observed in the formation of medical students in the middle of the 20th century, and Osler's idea of equanimity. Your story is one of not being very detached. It's obvious you're not detached from Fred. And so I'm curious your thoughts about that as a professional, how you understand what's the right kind of attachment and detachment with our patients?
It is a virtue to try to figure out what the mean is, right? In this, and you don't want, you sort of can't have this kind of relationship with every patient, right? And there are special ones. That's certainly true. I do think that the virtue of equanimity is real and good and valuable for healthcare professionals. We do want to be concerned about our patients, but the relationship with them is not friendship. And even, I'd say, even though I was closer to Fred, he wasn't my friend. I wasn't Fred's friend. There was still a kind of professional distance from him, which is for the value of, for the good of patients, I think. So Osler says in that essay, Equanimitas, that the way you get to the point of equanimity is to recognize in the foibles of the patient foibles not unlike your own. So I think it's in recognizing our own finitude, our own limitations, part of which I learned from Fred, that we have the capacity to develop for ourselves the resources to be caring, but not to sort of so completely take on all of the suffering of our patients that we would burn out. The second thing that I think is important is to recognize that, one of the there are a number of studies now, and you're aware of this too, that have shown that one of the great protections from burnout in healthcare is having a well-developed spiritual life, so that having a community of people with whom to share one's own burdens, having the possibility of giving over to God instead of trying to take onto ourselves all the neediness of the world, is a way of both humbling us and I think helping to achieve that kind of balance. I think the criticism of a sort of early 20th century detachment, which was more kind of stoic and really distant, is healthy, but I wouldn't go so far as to sort of say that we, as some people have suggested, need to be the friends of our patients. I think that goes too far, and true equanimity is somewhere in between the two, maybe closer toward friendship, but not at friendship. And I would say that even with Fred, who was a special patient, he wasn't a friend.
And a related question, Dan, is, the story, I'm struck by all that's going on. You have cancer, advance directive, Tarsiva, saline, negotiation of hospice, rosary beads, praying for him, talking to him about your thoughts about God, conversation about damnation and sin and reconciliation. When you think about that, how would you speak to how all of that is connected to being a healthcare practitioner? We're frequently taught implicitly as well as explicitly to be careful about professional boundaries, and yet it does seem, I think part of the power of the story is the way, it seems to me, it's touching something very deep about the wonder and mystery and goodness of the work of medicine, which is really connecting with human beings. So what are your thoughts on that?
Yeah. I think one of the salient features of literature and medicine is, particularly for medical students who haven't had these kinds of relationships with patients yet, to read stories and realize that the history we typically take is like the tip of the iceberg, right? You really don't know what's going on in the life of most of your patients. And even with this, there's still a lot of mystery in who Fred was. I wasn't his friend. I didn't know a lot about the answers to some of the questions I even thought about asking, and to recognize that there's a lot of detail in here, but there's a lot of detail in everybody's life, and everybody's dying, and everybody's got that, and to recognize that people, take their untied endings all with them too when they die. It's not clean and perfect. And one of the problems sometimes in contemporary palliative care that David Barnard has written about is this sort of move toward triumphalism. Like we're going to make you, we're going to give you, this perfect, death, and it is not possible. We're human beings, and so I think that that's part of what is important here. That this kind of detail is and more is present in the life of everybody. And you're right. One of the privileges that, particularly for somebody like me in general internal medicine, is getting to know people and to be a part of their life in a way that's, not completely a friend, but a helping relationship, and a valuable one that I think can itself be therapeutic. And goes when it goes on for a long time. I mean, one of the most wonderful things that's happened to me after having been at Georgetown 30 years ago, going away to New York and Chicago and coming back, is there have been a couple of patients who've come back to me who remembered me from having cared for them earlier, and that's such a gift, So,
one more question in that vein. That in the story, Fred suffered physically, suffered. You talked about a blueness. Suffered emotionally, spiritually. You treated him with morphine and hydromorphone or hydrocodone, one of those, and you at some point started Paxil, paroxetine. You prayed with him. How do you discern when the suffering that you encounter is something for which medicine is a fitting response versus praying with a patient or some other kind of response?
Yeah, Paul Ramsey, although I've never found the exact quote, somebody else quoted him as saying once that the function of medicine is not to relieve the human condition of the human condition, right? And we need to recognize the limits of what medicine is and what medicine can do. But also recognize that while the primary focus of medicine is caring for people's finitude in and through their bodily finitude, that human beings are beings in relationship, and that those relationships are with other people, they're with society, they're with God, and that those relationships are deeply affected by brokenness in body, right? So, those of you who care for patients, particularly those who are dying, why is it so uncannily that brokenness in body reminds patients of brokenness in their relationships, right? Why do so many people who are dying want to sort of reconcile with their, estranged son or daughter or uncle or whoever it might be, right? There's a connectedness to that, and we have to recognize that, but we also have to recognize the limits of the medical craft. One of the least developed parts of the philosophy of medicine is the philosophy of therapy. And one of what I've called the canons of therapy is the canon of discretion, which means knowing the limits of medicine, what medicine can actually do, what its boundaries are, and our own limits as individual practitioners. And this, I think, from the Hippocratic Oath is part of what the clause is about. I won't treat the stone, but will, those suffering from the stone, but will defer to others as our experts in that, right? It's this sort of sense that we all need to recognize our own limits and then ask for help from other people who can assist the patient in the parts of their suffering that are not primarily medical. If we ignore it, that's a problem, these other non-medical parts, because it's so tied in, but we also need to know our limits and not try to be the person who treats it, or even I think more horrifically, react to non-medical suffering with a medical intervention, right? Which I think is really weird. So somebody says, I think I'm going to be damned, and we say, well, here's some Haldol, right? Or here you're hallucinating, obviously, I'll sedate you, right? So those are deep problems, I think, so.
In the interest of time, I'm going to ask one more question. And I'm going to combine these two things into one question. And you can take either part of this or both parts. If you could do it all over again with Fred, looking back from this vantage, what would you do differently, if anything? And how does love fit into your care for patients, or should it figure into clinicians' care for patients?
Yeah. The answer to the first question, I don't think I would do anything differently. I sort of wrote all this down right after coming off the beach, because it all just sort of, sort of came to me in this sort of rush. And the truth of the story is the gift. And there's, nothing to change about that. It's what happened, and the Franciscan spiritual writer Richard Rohr once said, I think very succinctly, God comes to you disguised as your life. And this is what happened, and if I can't find God there, or God doesn't find me there, then there's a problem. So I don't think I'd change anything. I learned something from it, and that's part of what happened, and because we're all in the process of growing. And the second question, what's love got to do with it? That's from Tina Turner. I think it has everything in some ways to do with it, particularly for anybody who professes to be a Christian and is involved in healthcare. I mean, this is the root of it, and if we have Christian healthcare institutions, it's got to be rooted in love, and the love is agape, which is not philia, right? So it's not the love of friendship, but this love of giving towards other persons, recognizing their brokenness, which is like our own brokenness, and our need to reach out to our brothers and sisters in love. I think it's the root. It's sort of in some ways why I think why the miracles of the New Testament are miracles of healing, because this sort of act of healing is symbolic, I think, of the love and reconciliation that God offers to all of us. It's not, the miracles of the New Testament are not burning bushes or pillars of fire, but acts of healing, which are acts fundamentally of love.
Friends, outside these doors is dessert and coffee. I'm sorry, these doors. That door. Oh, no, not outside the door. Inside these doors, in the back, is dessert. Please stick around and visit with each other, visit with us. Dr. Sulmacy will be around. You can ask him questions. On behalf of all of us in the Theology, Medicine, and Culture Initiative, and I want to thank also the Trent Center for Bioethics, Humanities, and History of Medicine, and everybody who was involved in helping put this together. We thank you for your attention and for coming tonight. And please join me in thanking Dr. Sulmacy.